patients after they've had it. Thank you very much.
Thanks, Nick. Moving on, we're going to hear from our president, Dr. John Mazewski. He's going to talk about the SIS IntraAbdominal guidelines.
Thank you very much. My task is to talk about the guidelines. I would prefer actually not talking about the guidelines for the next 3 days, which would probably take to cover them. And I'm really going to focus on try to point out where the guidelines discuss things related to sepsis and septic shock, although we didn't specifically divide them that way. I do have the following disclosures to make. I will be talking a little bit about antibiotic therapy. I've had a number of relationships with various companies that produce antibiotics. However, I'm not going to be specifically trying to recommend any particular one for your use. As far as providing where I'd like to go, I'm going to first of all review some of the surviving sepsis guideline measures that may be applicable to patients with intra-abdominal infections. I'm going to spend some time talking about risk stratification because I think this is extremely important in looking how we treat patients, and then really try to delve into the areas I think of greatest interest to surgeons, which are particularly talking about source control in higher risk patients and looking at options for antimicrobial therapy in these patients. To start off with a caveat, and I'm going to apologize for there's going to be lots and lots of verbiage here. I don't have a lot of pretty pictures to throw on there, but I do think it's important to keep in thought what exactly we're trying to do with clinical practice guidelines, which I've been participating in a number of them, and they're attempts to guide or to assist practitioners in providing optimal therapy. I think it's very important, though, the caveat on practice guidelines that they're not a substitute for clinical judgment, that clinical discretion is of utmost importance, and for individual patients, no guideline can ever be so specific that it tells you how to apply that to every single patient and situation. So again, as we talk about guidelines, I think it's important to keep this caveat in mind. So with that, I would like to start off with talking a little bit about the surviving sepsis guidelines. I have the privilege as the representative of SIS to participate in there. There are a couple other members of our organization, Craig Coopersmith and John Marshall, who also participated in the most recent surviving sepsis guidelines. As you can see, there's about 58 authors, so we certainly weren't by any means a majority. And I'd like to go through some of the thoughts that they have on source control and antimicrobial therapy. I'm going to again reproduce what the surviving sepsis guidelines say. And as I go through, the ones that are in yellow are sort of the ones that I think that I'm going to try to address as we go along in this talk. So first of all, with regard to source control, there was actually only really one caveat that they put in there about source control that I think is pertinent, and that is we recommend that source control essentially be done as soon as possible for patients with sepsis or septic shock, that is at least as soon as it's logistically practical. As I mentioned, with regard to antimicrobial therapy, there are far more things, and as a matter of fact, we touched on most of these throughout the guidelines. Again, I'm going to mention some things because there are some things that we may disagree or have a little bit different take on in the intra-abdominal infection guidelines than what were produced with the surviving sepsis guidelines. But again, recommendation for administration of IV antimicrobials as soon as possible. You've already heard that. Recommend empiric broad spectrum therapy, again looking at that it ought to be adequate to cover the suspected pathogens. I'm not going to talk about these issues, but we touched on them. This is 1. 3 is basically de-escalation of therapy. 4 is not using antibiotics for situations of prophylaxis. Specifically, we touched on severe pancreatitis. 5 is looking at optimization of dosing of antibiotics. Again, there's a large section in the IAI guideline about this, but I'm not going to talk too much about that. I do have a little bit of something to say about the suggestion that's made for empiric combination therapy, that is using 2 antibiotics of a class for treating patients. We'll show a little bit of evidence or discuss a little bit about that, why that might not be as important for intra-abdominal. But again, this is adjudicated a little bit by a subsequent guideline that says, well, if you've got, think about it for septic shock, but don't necessarily do it for severe sepsis or for sepsis, since we don't have severe sepsis. Finally, I'm not going to I'm not going to get into a big discussion about the de-escalation again, which again I think is an important caveat. And then I think very pertinent to this society, particularly duration of therapy, particularly with regard to Rob Sawyer and the Stop It trial that we have carried out. I think there's going to be some very fundamental things to say about duration of therapy. And again, I'll call your attention just to recommendation 10, which recommends 7 to 10 days of therapy, but then hedges a little bit in recommendation 12, which I think is directly as a result of some of the work that we've done, and says, well, maybe if you've got improvement, you don't need to use that long of antimicrobial therapy. So I'll try to hit this at the end. So again, I'm going to go to the practice guidelines that we published earlier this year in 2017. Again, I'm going to acknowledge, you can see the authors up there. There are many of these. I really need to acknowledge all my co-authors who did a lot of work on these particular guidelines. It took far longer than we were expecting, and I'd really can't mention them all by name, but I would really salute them for having participated in this. And again, I'd like to review the fact that our society has really been fundamental in producing clinical practice guidelines related to intra-abdominal infection. In fact, the first guideline was produced in 1992. John Bonin was the lead author, Joe Solomkin, Patch Dellinger, others that are still active in the society were also members of that first guideline task force. In 2002, I was tasked with revising those guidelines, which we undertook. We did a joint guideline, a revision of the 2002 guidelines in 2010 with IDSA. For various reasons, we elected to go back and do solo publishing guideline that was published again in 2017. We do have extensive evidence reviews that are included as appendices in this publication. Don Fry was already satisfied with 68 pages out of the surgical infection, so I don't think he wanted too many more pages listed. I think a key element that we're going to try to be doing is we are currently, there is an app that hopefully will allow this guideline to be implemented that is under development and hopefully will be coming out in the next several months. Principles we use to develop the guideline, again, clinical evidence. We still follow basic grade criteria, that is the prospective trials are most important, but recognizing the importance of using other types of evidence, indirect evidence, epidemiologic evidence, which may be of importance, and then grading recommendations according to their applicability. And particularly here, we looked at benefit and risk assessments for individual patient types. Finally, there are some specific issues related to antimicrobial therapy, which I think are important, and that is certainly the emerging resistance of bacteria to a number of the antibiotics. This is particularly important in other parts of the world, although it's going to be certainly something we face. And finally, the overall issue of antimicrobial stewardship. How do we adopt guidelines so that we don't excessively use antimicrobials? The fundamental principles really of treating, as we've stressed in the guidelines and previous guidelines, there's sort of a threefold attack on patients that present with intra-abdominal infection, particularly those that present, the sicker patients that present with sepsis or septic shock. And it's basically resuscitation stabilization. You've already heard a lot about resuscitation. I'm not going to go back into any of that. Source control is fundamental to treating patients with intra-abdominal infection, as we'll show, and then antimicrobial therapy. Now, implicit in this, in making these applicable, in fact, to patients, a wide variety of patients with intra-abdominal infections, is the idea of risk stratification. I'm not going to talk about treating perforated appendicitis in a 20-year-old here who's going to get better, generally with conventional therapy. We don't really need to go over in great depth how to treat them necessarily, the patient with perforated appendicitis. We can make recommendations. Unfortunately, most of our data and good data is about treating that type of patient. And when we come down to start talking about the seriously ill patient, find that the data, there's actually a relative paucity of data. So in terms of risk stratification, what do we actually say? And essentially we say we try to take the patient characteristics, phenotypic, the physiologic factors, some aspects of the infection, the risk for resistant organisms into account, and then put them into essentially 3 buckets. And this is very similar to what we've done in the 3 in the previous guidelines. Essentially, First of all, make a decision. Does this patient have a healthcare-associated infection or a hospital-associated infection or a community-acquired infection? Because the microbiologic changes in these patients are substantial in terms of implications for antimicrobial therapy, perhaps not so much in terms of source control. Once you decide that the patient has a healthcare-associated infection, then then we basically go into a certain class. However, the patients with community-acquired infections, what we really would emphasize is then risk stratifying these patients. How sick are these patients? Do they have sepsis, sepsis shock? If you have Apache scores, is it elevated? Are these patients that you're going to have problems doing source control on? Are there major medical comorbidities? And again, if you're in one of these higher risk categories, we came up with a system. This is highly arbitrary now. We hope that this gets validated with time. But to try to say, what are the factors that in large numbers of multivariable analyses have really proven to identify patients at higher risks of mortality with these particular disease processes? So once you've risk stratified the patient, which will be part of this app that we're developing, what about source control? What are the elements of source control that are important in the sicker patients? So first of all, why source control? What is the importance of source control? Generally with a surgical audience, it's not necessary to describe, but again, going through and looking at the multivariate analyses that have been done over the years, if you look at the odds ratio, failure to achieve source control has been uniformly associated with the highest mortality in groups of patients with intraabdominal infection. And this applies across a wide variety of different types of studies that have been carried out. I don't think that with this particular audience we need to argue much about the essential nature of source control. Well, when should you do source control? Remember, surviving sepsis says as soon as feasible. Well, we basically reflect that, but in fact the data behind timing of source control is surprisingly poor as far as when it goes. Generally, the association is greater than 24 hours, but is it less for patients with sepsis or septic shock? We have suggested that, but again, there's very little data to confirm whether or not that's true. What about how you do source control? And I think this is probably one of the most important points we look at in terms of our seriously ill patients with sepsis and septic shock. Certainly we can use percutaneous drainage. There is a popularization of the use of damage control laparotomy in many of these patients. Again, what's the data behind this? Unfortunately, again, with percutaneous drainage, although we use it widely, most of the data comes from less severely ill patients. So we know that it's highly successful in most patients that have localized fluid collections. However, in critically ill patients, there is some baseline data that says you have the higher your Apache score, the less likely it is to necessarily be associated with be successful. And again, a lot of this refers to, you know, even though that you can do clinically accurate, a clinically good drainage procedure, it may not cure the patient. What about damage control laparotomy? Again, we've adopted damage control laparotomy relatively freely from the trauma experience. I think, again, the idea of making a limited procedure in these patients is adequate. We have identified certain groups of patients in our guidelines that we think are candidates for abbreviated laparotomy or damage control laparotomy, temporary abdominal enclosure, including those that are at risk for intra-abdominal hypertension, patients who have exhausted physiological resources, however you define that, patients in whom you can't achieve adequate source control, or those who you're planning to do a second look procedure in any case, for instance, the patient that has mesenteric ischemia. So again, we think it's valuable. What about in all patients though? I think again, in all patients with severe peritonitis, this was looked at in a large European study that was carried out about a decade ago, prospective randomized controlled trial of mandatory laparotomy versus on-demand laparotomy. I think many of us are aware of this study, which showed absolutely no difference going to the mandatory laparotomy approach. There was no difference in mortality. The only difference was that your hospital lengths of stay and your overall expenses were higher if you underwent this process of mandatory laparotomy. So I think we can safely say that, again, damage control laparotomy, if we're going to utilize it, has to be limited to certain patients that are probably going to benefit from this and not used as a uniform procedure. So again, to summarize source control in terms of what we think in the most severely ill patient. It clearly is an important component of the management of the patient with intra-abdominal infection. We think we can use less invasive techniques, but again, with the caveat that they may not necessarily be successful. Temporizing measures are appropriate for certain critically ill patients, but mandatory laparotomy we don't feel is necessary in all of these patients. I'd like to turn now to antimicrobial therapy, the sort of third arm that we're going to discuss. Again, in terms of source control, antimicrobial therapy is really an adjunct. And I think an important caveat there, again, we don't consider antimicrobial therapy as the primary therapy for very many patients. There are certain ideas. It certainly can perhaps prevent dissemination of microorganisms during the source control procedure, can eradicate residual organisms, but it's, again, not the primary therapy. The basic principles of antimicrobial therapy for intra-abdominal infection have been well established for the past probably 40 to 50 years, that you want to cover basically gram-negative Enterobacteriaceae, some of the gram-positive cocci, enteric anaerobes. With respect, though, to the higher risk patients and those that may be at risk for having resistant organisms, we worry about things like Enterococci, occasionally Staphylococci, resistant gram-negative bacilli, fungal organisms, particularly Candida. And essentially, we base our therapy on these patients, both on the patient's risk for an adverse outcome as well as their risk of resistant microorganisms. So again, in the seriously ill patients, we're looking at a little bit more aggressive approach to antimicrobial therapy. Again, why is this? Well, again, if we go back and look at the question of how adequate is antimicrobial therapy, if one looks through the data, one again finds that there's a tendency, although not as dramatic as seen, for instance, with patients with bacteremia, those with pneumonia, but one sees there is an association between inadequate antimicrobial therapy, that is, that does not cover the organisms cultured out, and increased mortality. And there's some 9 studies that we looked at looking at this. In no study did it suggest that inadequate antimicrobial therapy was better. I mean, in some of them it was relatively close. So again, I think the provision of adequate antimicrobial therapy up front in the seriously ill patient is in fact important in these patients. What about, so how do we go about trying to do this? And again, this is the part that makes it somewhat difficult. Again, for the patients with community-acquired intra-abdominal infection, they have a slight tendency for some of these more resistant organisms, but it's not overwhelming. And again, these are patients that have not been exposed to the hospital environment, have not been exposed to a lot of broad-spectrum therapy. So in these patients, we have a series of antibiotics that we would recommend, I'll show in a minute, but we do not recommend going to the efforts to provide adjunctive aminoglycoside or fluoroquinolone double therapy for these particular patients. There have been studies that have shown, in fact, that double coverage in patients, seriously ill patients with intra-abdominal infections, does not confer any additional benefit. We would consider certainly addition of something to cover enterococci. This is an extremely controversial area, and I'm going to duck talking a lot about it. There are certainly studies that are for and against this. We don't recommend routine coverage of fungal organisms except in critically ill patients who have an upper gastrointestinal perforation. Again, pointing out this is empiric therapy, not definitive therapy. We should de-escalate to those. These are the basic recommendations. We've come over here on the right side for patients, the higher risk patients. You can look through the list here. I'm not going to go over this to any great extent. Well, as I mentioned, in our initial risk stratification, we break out the patients that have a healthcare or hospital-associated intra-abdominal infection from those that have a community-acquired infection. There's a very fundamental reason for this. If you look at all the studies, you see that there's a very radical change that occurs in the microbiology, even with exposure to only 3 or 4 days of antimicrobial therapy. And in fact, you select out certain organisms. The ones that we're particularly concerned about with healthcare-associated infection are listed here. Again, we're going to talk about Enterococci, MRSA, although again, it's relatively infrequent, a major issue related to resistant gram-negative organisms, and finally, Candida, including non-Candida albicans species that we need to consider. So again, what our overall recommendation is, start up with broader spectrum therapy similar to the high-risk patient with a community-acquired intra-abdominal infection, but then you may want to consider some of these other agents, adjunctive agents, to cover some of these organisms that might in fact be there. We've tried to go through through risk factors so that one could potentially identify who's at risk for these various organisms. Unfortunately, one very quickly finds that these risk factors all meld into each other. What are they? The patient that's been in the hospital, the patient that's been exposed to broad spectrum therapy, the patients that's sicker tend to come together. So we've gone through, although I don't think it's necessarily as useful as I'd like to see, to look at what are the risk factors for each specific type of problem. I would point out for enterococci, it's basically any patient with a postoperative infection. In fact, we see up to 50% of these patients having enterococci. Again, we can argue about whether or not coverage is necessary or not, but at least we know what the microbiology. Another group of patients that's been identified are those who are already known to be colonized with VRE. If you have VRE in your colon and you have a perforation, you can bet you're going to have VRE as one of the infecting organisms. So in those circumstances, we would consider covering those organisms. What about MRSA? Well, here it's distinctly uncommon to have an MRSA infection, but it does occur within the abdomen. And who do we suspect? Again, those that are already colonized or have had prior experience with MRSA are those that may in fact need coverage for that organism. What about the resistant gram-negatives? And this is where it becomes extremely difficult because we're dealing with all sorts of types of organisms. These can be ESBL producers. You may have an AMP-C beta-lactamase producer. You can maybe in certain areas of the world have carbapenem-resistant enterococci, which may be the KPCs. They may be the metallo-beta-lactamase producers. You can deal with multiply resistant gram-negatives, such as Pseudomonas and Acinetobacter. So there's a tremendous variety of organisms there that we have to deal with. And again, the risk factors for those are not well known. One risk factor is if you already know the patient's been previously infected with one of these organisms or is colonized with one of these organisms, that would make a rationale for directing therapy toward that organism. But most of us don't screen and try to go out and look for resistant gram-negative organisms. What can help? Here we advocate really using local antibiograms. Again, the types of gram-negative organisms you have in your surgical intensive care unit or your facility are going to likely predict what sort of gram-negatives, resistant gram-negatives you might face and what sort of antimicrobial therapy you might want to employ in these patients. Finally, with regard to Candida, there is actually a little bit better information available on who's at risk. Certainly patients, if you get a gram stain positive for Candida, they are colonized already for yeast at multiple sites, although there's a little bit of controversy with this. Patients who are suspected of being colonized because of prolonged antimicrobial courses. And then there are certain risk factors related to the intra-abdominal infection. Again, upper GI perforations, recurrent lower GI perforations, surgically treated acute pancreatitis are patients that have been identified in that sense. Well, this is a very large table that comes from the guideline. And here we're saying, what do you want to add to the basic therapy? Again, the general approach is very similar to that we use in the higher risk patients with community-acquired infection, relatively broad spectrum therapy initially. It can be de-escalated. But then additional therapy, if needed for some of these organisms, depending on what you're predicting, is going to be present based on the risk factors of that particular patient. Again, it's not entirely satisfactory. We don't have good risk factor analyses for specific patients, but at least it provides a guide for where you want to start off with. Finally, I think it's necessary to come back. I think it's very important to talk about duration. Again, as one of the Stop It investigators, we certainly go out to Rob Sawyer who developed this protocol. I think it's a marvelous study that has really helped us a lot with intra-abdominal infection. And I'll remind you again, the overall results of the Stop It trial. It was 4 days of therapy versus symptom-based therapy, which actually was 8 days of therapy, which could be considered long course therapy. Again, between the experimental group, 4 days of therapy, and the control group, absolutely no difference in outcomes whatsoever. Apropos to this, I think are some of the subgroup analyses that were performed as part of the original New England Journal article, showing patients with elevated Apache 2 scores, in fact, did not do worse with with short course therapy. If anything, they did better. Similarly, patients that have healthcare associated infections did not do worse with short-term therapy compared to those others. There have been additional studies. Dr. Rattan, I think from Nick Namias's institution, has looked at subgroup analyses and found no difference in outcome between patients that present with sepsis, again, indicating that short course therapy can be utilized in those patients. The caveat, of course, is that this group of patients was not necessarily as sick as some of the patients in septic shock that we've dealt with. So again, with regard to duration, we recommend no more than 4 full days of therapy. And even in patients that have secondary bacteremia, we're not recommending long-term courses based on some other data. So again, with regard to antimicrobial therapy, we recommend targeting these specific pathogens. They should cover the basic organisms, use broader spectrum therapy for the higher risk patients, again, with community-acquired infections or healthcare associated infections. And we recommend individual assessments for risk for some of these resistant organisms and application of local epidemiological data to assist in providing empiric therapy, and that short course therapy is really appropriate for most patients. Again, thank you for your attention.